Welcome, everyone. We'll get started. It's my pleasure to introduce today's speaker, Dr. Tina Hernandez-Boussard. Sorry. Dr. Hernandez-Boussard came from Stanford. She's currently associate professor in medicine, as well as other affiliations. Those are biomedical informatics, biomedical data sciences, and surgery. Her background contains the following landmarks. She received a bachelor's degree in biology and psychology in UC Irvine, followed by a master's degree in public health in epidemiology that's from Yale Medical School. Then PhD education in computational biology in University of Lyon. Then back to the States for many years in Stanford, initially with David Botkin.
Yes, yes.
Right. And then since 2011, she's on the faculty in Stanford as assistant professor, then rose through the ranks. Now she's associate professor. Her research is on health record informatics. In the past, we've learned of her work related to mining data in VA for prostate cancer and for a number of other conditions and try to improve the quality of care. So today we'll let her talk about her research. She's been funded with multiple streams from NIH, both past and ongoing ones. We'd like to hear about both the past and future ones. Her title is Leveraging Biomedical Big Data to Transform Healthcare Delivery. Welcome.
Perfect. Thank you. So thank you so much for having me here today. It's really a pleasure to be able to present this research to you. And I've had a wonderful day just meeting some of the faculty, some of the other people around campus, and learning about some of the really innovative research that you guys are doing. So it's a pleasure to come here and talk to you about some of the work that we're doing. So my work is really going to focus on using electronic medical records. And I think that we can all agree that in the era of electronic biomedical data, it's going to be possible to efficiently and accurately examine processes and outcomes of care with the goal to improve both the quality and outcomes of healthcare. And so I'm here to say that, really EHRs are not the future of healthcare. EHRs are healthcare, right? I mean, we've been having just so much hospitals and data coming from EHRs that's where we are today in healthcare. And if any of you have been following some of the literature for electronic medical records, you know that there are a lot of challenges in using these data. First, electronic medical records were not built for research purposes. They were built for billing purposes. So data are not structured according to patients or episodes of care. Second, utilization at bedside is not practical. There's been a lot of research recently talking about clinician burnout, frustration with using electronic medical records. They're saying they spend more time trying to get information into the medical record and out of the medical record than they have time to spend with their patients. Another challenge is that documentation is variable. There's a saying, garbage in, garbage out, and that's what we see in electronic medical records. Nobody's monitoring the type and quality of information that's being put into these medical records. Therefore, when we look at what's inside the electronic medical record, we have to deal with things like missing data, incorrect data, or outdated data. And for outdated data, this is becoming a real problem when we start looking at that. So if you think about one of the main pieces of an electronic medical record we look at is the problem list. So a patient comes in, they have a problem, and they get documented with that problem, usually associated with an ICD-9 code. Well, nobody's going back once that problem is resolved to take that issue off of their problem list. We were looking in our healthcare records, and we had, thousands of patients who had pneumonia for over 10 years. And so what had happened was the patients came in, diagnosed with pneumonia, they got on an antibiotic, they completed their antibiotic, but nobody went back to the healthcare record to mark that this was resolved. And so you have to be creative when you're looking at this data. Finally, interoperability and exchange are limited. There's disconnects between the technical, algorithmic, and incentive motivations to really share these data. However, we're not going back to paper records, right? So that's what I'm saying. Electronic healthcare records are here today. And, you know, looking at some of the work from your former colleague, Julia Adler-Milstein, this was something she published just a couple months ago. She shows that over 90% of hospitals in the US have some form of an electronic medical record. So we need to think about these problems, and we need to identify solutions on how we can deal with these. And so a little bit of background about myself. So I first began my training in the gene expression era. And I, along with Xiong Li, were some of the first people working in the gene expression world. And I think there are striking similarities between the challenges we faced in the early gene expression era that are similar to the new barriers that limit the utilization of EHRs for scientific research and clinical care. So what were some of these earlier challenges? Let's think about these and think about how they are similar to our electronic healthcare data. Well, the first problem we had with gene expression data was data storage and organization. When we first started creating, and I'm not going to date myself, but you will get a sense for how old I am, but when we were first cloning those first spotted arrays, the data were stored in text files. They were stored in a directory. We had lots of problems on how to identify information within these text files, how to store them. So first thing we did was we developed a database, right? So we took this information from the text files and we mapped it to an Oracle database. Second problem was we didn't know how to extract the knowledge and information that was on these arrays. So we had these ESTs. This was before the sequencing of the human genome. So we had to think of how do we take this clone that's spotted on our array and map it to a specific gene, a location, you know, how do we deal with that? So we developed software and tools to actually take that information and get it back to the clinician and researcher. So this was one of the tools we built a long time ago now, and it was the source, which was the Stanford online resource for clones and ESTs. And it's actually still being used today. So I was kind of surprised to see it was still up and going. But so similar problems with electronic medical records. We have all this data going in. We don't know how to get it out. It's stored in different formats, various ways. And so these are challenges that we're facing. Finally, the next challenge we had was thinking about novel statistical methods to deal with the data. Again, when we first started using microarrays, we had to think about how these data are going to be clustered, how we're going to do unsupervised learning for them. So it all opened up a lot of opportunities with our biostats department to think about what are new ways that you can think about analyzing these data, processing these data. So my work over the past decade has really been focusing on how we overcome these barriers with electronic medical records. My work is focused on taking really an interdisciplinary approach to leveraging the granular data that's stored in the records. And we tackle this by 4 specific items. So first, we look at gathering and organizing information from multiple data sources. So we're pulling information from our electronic medical records, but we're also linking these data to outside resources to get a more granular capture of the data. We're applying novel data mining tools to identify and extract information from the medical records. This leads to new statistical challenges that we're trying to address and think about. And also, I think one of the important aspects is you need to think really hard about the data challenges and how we overcome them. And then that also leverages what questions you can ask of EMR data. There's a lot of frustration when we work with clinicians who come in and they say, you know, I want to look at longitudinal diabetes patients who've been on this particular drug. Well, longitudinal data is difficult in EHR, certainly at a tertiary care system such as Stanford and Michigan, where people come in, they get their healthcare services, and then they leave. So we have spotty, sparse information. So you need to think about the questions you're asking to these, to the electronic medical records. So let's talk a little bit about EHR organization and storage. what does an episode look like in an electronic medical record? So at Stanford, we use Epic, and I believe you're using Epic here also. So as I mentioned, EHRs are not developed for research. In our Epic Clarity system, we have over 15,000 tables that stores the data. Data are stored for one particular variable. It can be stored in multiple locations, and the same information could be stored in various types of data. For example, we're interested, I have a cohort that looks at prostate cancer. We're looking at PSA levels. So that can be stored as a lab value. It can be stored in the text, so the clinician might just write it in the text. It can be stored as a PDF file that's coming in from an outside consultant. So these data are stored in multiple places and in multiple types. Second, there's no standard way to represent data, variables, or outcomes of interest. It's really clinician-based, division-based. A particular department might have a way of recording some information that might be completely different from another department. And so there's no standardized way to store that. So we've put a lot of effort in defining clinical cohorts of interest. So how do we do that? We first identify a topic. So for example, in my work, we've been working a lot with prostate cancer. So we work closely with the clinicians to define, we do a manual chart review to define our variables of clinical interest. We want to know what these variables are, how they're stored, where they're stored. And so we do manual chart review on, about 50 or 100 records before we even begin the project to identify where this information is. We use all available data for a cohort. So say, for example, if I'm interested in identifying a cohort of prostate cancer patients, I'm going to use diagnosis codes, procedure codes. There is free text. There might be lab values. We pull all information to get a comprehensive cohort. And then we develop electronic phenotypes that, and so are any of you familiar with phkb.org? It's been used to store genotype phenotype information. It was mainly developed for GWAS studies, but it's to identify electronic cohorts. And so we have developed these electronic phenotypes for our patients of interest. And so what does that mean? What do these look like? And I'm not sure if you can see this, but it was just kind of to give you an idea of the types of information that are stored in these phenotypes. So you generally have a flow diagram. So how would you think about identifying that cohort of interest? You then have a list of like ICD-9 and clinical ICD-9 and 10 codes and clinical terms that you would also use to define the cohort. And then you have an NLP piece to think about how you would extract this information. And by depositing it in phkb.org, what we do is release it. We release it once a publication is released, and that allows other people to utilize your phenotype to identify populations in their own cohorts. You can get accuracy scores across institutes that can help you refine that cohort. And it just helps disseminate this important piece of cohort identification. So, right, so when we build these EHR cohorts, as I said, it requires a multidisciplinary team. We have clinical people, we have informatics, we have technology, we have people from HSR helping us think about the question. We use all available data. We use all data available, as I mentioned. And we also link to, in addition to just grabbing the information in the EHRs, we link the EHR information to genetics, to clinical trials that are going on within our institute. Clinicians often have their personal databases, so we match those up and pull those into our cohorts. And also patient surveys, and a lot of the patient surveys get at quality of life, some other types of information. And so we pull all of those together into our cohort. And then we link to outside data sets. So for example, for our prostate cancer cohort, we link to the California Cancer Registry. And we do that for several reasons. One, it allows us to identify patients who were diagnosed at Stanford but sought treatment outside of our institute. It allows us to follow up on longitudinal data, so they capture information on metastatic disease, survival, et cetera, that we might not necessarily have in our electronic healthcare records. And then it also contains detailed, curated information on pathology, histology, et cetera. So we link to the database, and we pull all this information into our cohort. We have other data sets. We're also looking at postoperative pain. For those, we link to different substance abuse information. So the Cures database is a registry of all controlled substances in the state of California. And then we also look at census data. So some of our questions are related to access to care or patient outcomes. So we have the patient zip code in our electronic medical records. So we look at geographical information systems to get information on where, what's going on in their local zip codes. So what is the crime rate? What is, how many grocery stores? You can get information on how many grocery stores are in a walking distance. You can start looking at distance to their care centers. So what is the burden on the patient coming back and forth to the clinic? So you can start asking some really interesting sort of health services, health policy questions by capturing all these data. So what we do is we take information from across all the data fields to build these cohorts so that we can really drill down and look at an individual and try and help provide evidence that can improve the care they receive. And so I told you about we've developed a cohort for prostate cancer. So in our prostate cancer cohort, we've identified several subpopulations. Our primary population is prostate cancer patients seeking initial treatment at our university. We have the full episode of care for these patients. So we see previous risk factors, we see processes of care, we get subsequential diagnoses, survival and metastatic status, and then that allows us to start developing prediction models, some classifiers to look at some of these different outcomes using all the available data we have available. We have a secondary cohort, which are patients diagnosed with prostate cancer seeking treatment for something else. And we also have a screening cohort. So I have a lot of interest in health services research. So we look at guideline recommendations and things like that. So we've pulled in our entire male population 35 and over to look at screening pattern differences to see who's being screened for prostate cancer, who's not being screened. So you can see by developing these cohorts, you just have so many questions that you can start asking of this cohort from all different directions. We have health services questions, clinical questions, epidemiology questions. And so it really develops this really nice resource. So the second piece when we're thinking about building this cohort is we need to start thinking about standardized formats for tool development. So it's great what I'm building at Stanford. I've built this cohort. We're doing a great job with this. But what if I want to implement this at Michigan? How do we start thinking about that? And so there's two initiatives that we have been really working closely with and following. The first is the Observational Medical Outcomes Partnership, which is called OMOP. And it's actually, they're actually no longer existing as a community, but what they've developed is a common data model to evaluate data standards, comparative effectiveness research, personalized risk prediction, and data characterization using this common data model. I'll walk you through how we developed this, but what it is a standardized way to identify things within the electronic healthcare records. So patient has to be named, patient underscore N0 or something like that. And then in addition to OMOP, there is the Odyssey work group. And Odyssey has leveraged the OMOP common data model to build several software tools. So they're developing algorithms that can be shared across systems to look at data characterization, prediction models, and data quality. So how does that work? So the first step to doing this is you have to convert your electronic medical records to the OMOP format. And so what you do is they have developed an extract, transform, load program that allows you to efficiently map your information to the common data format. It's something that really needs to be done in combination with a clinician who really understands the variables. They have software developed to implement that. And then they also have testing. So it's a reiterative thing. So you map your data, you do tests, you might have to go back and change some of the mappings. So what does the Odyssey and OMAP give you? So right now for the common data model from OMAP, they have over 50 databases that have mapped to this model. What's interesting is the VA has now announced that they are going to map their EHR data to this common data model. The data translation, so it conserves the source values. All the data can be maintained. But what it really allows you to do is develop algorithms, develop prediction models using your own EHR, and share these models with other institutes, and they can implement them within 24 hours because you're using the same data structure, you're using the same formats. So it can be very powerful when you think about sharing data, sharing algorithms. So resources needed in order to do this, as I said, it's really a multidisciplinary adventure. You need to have feedback from the clinicians, from the IT, and from a programmer who can actually run the programs. And so what we've been doing with some of these formats, they have one of the features they've developed is called Aphrodite. And what Aphrodite does is it takes a clinical note and it pulls out, let me see if this is working. Well, there we go. So it takes a clinical note and it pulls out, for example, all ICD-9 codes, all structured data, all lab features, and it's developing prediction models. So it will give you a vector of occurrences for all of these different aspects in your electronic medical record, and it will start helping you develop some prediction models, giving you all the information you need to test recall, sensitivity, accuracy. These models don't yet include the free text. Oops, don't yet include the free text, but it's something that they're working on, and so there's been a lot of effort in developing these common data tools for this. So the next problem when we're thinking about using electronic healthcare records is extracting that data, that information that's embedded within the record. So one thing to note is that about 80% of EHRs are stored as unstructured free text. But that is really the granularity, that's really the important information that we want to get out. So we've developed a few pipelines to extract this information from the from the medical record. And what we do is we take the free text. We have an NLP engine, so a natural language pipeline engine that does first some text pre-processing. So if the text is in a note that is for history, we assume it's going to be past history. There's a lot of pre-processing you can do to help, make the pipeline run more efficiently. We then do term recognition. So we give it either a list of terms that we want to recognize in the text, or we do index the entire record based on ontologies and key terms of interest. And then we extract the knowledge. And so we can either take the knowledge that's extracted and store it back in our database, or we put it in a matrix of terms that, for example, in this matrix, we have patients are rows, our clinical terms are columns, and then you can look across episodes of care. So regarding the NLP, I think it doesn't really matter. There's so many off-the-shelf tools right now to use NLP. And we've tried a variety of different tools to extract this information. I don't think we have found it's not important the type of tool you use, it's just important that you're able to use a tool to extract this information. So this first pipeline here, we index all terms within the note using medical ontologies, and then we extract the terms of interest that we want to look at. Put it in a matrix, and then we can evaluate it. The second one, we've used Gate, which is a standalone software to extract text from EHR. both of them are equivalent. Both of them are giving us fairly similar results as far as accuracy and recall. And so I don't want to, I mean, I would love to talk to you more about some of the, more in detail about the algorithms, but it's been our experience that we haven't seen a big difference in using these to extract the information from the medical records. It's just important that you use something to extract these. And so what do we do with this information? And so one of the reasons why we want to extract the text, as I said, is because 80% of the information is stored in this unstructured text. So I just wanted to give you a view of some of the research we're doing on this. So in our prostate cancer, there are outcomes that are known as patient-centered outcomes, which are outcomes that are not measured by lab values or structured data. They can only be reported by the patients. And so we're really interested, they're very important following prostatectomy, so it can be urinary incontinence or rectal dysfunction. So when a patient goes to receive treatment, they have to decide, which treatment is better for me. Do I want a treatment that has higher rates of urinary incontinence, or do I want a treatment that has higher rates of erectile dysfunction? It's a very personal question, and we don't have a lot of evidence to guide these treatment decisions. So we sought to look in in the medical records to see, one, is this information recorded? And here you see that we looked in 5,000 patients, and we saw that of the 5,000 patients, only 4 patients had urinary incontinence recorded as an ICD-9 code, but we had about 1,500 patients who had it recorded in the text. We were able to extract it. So this information is in the medical record. Next question is, how good are the clinicians at documenting this information? So these are some results looking at the concordance between the information we found in our unstructured text and those reported by the patient in a patient survey. And so you can see the blue line is the rates extracted from the unstructured text using our NLP algorithms. And the green line is the information from a patient survey, a mailed out survey. So you can see we're highly, highly concordant in these outcomes. So it's being documented, and it's being documented accurately. Now, this might be a special case. As I said, this is a very important outcome following prostate cancer. And so that's why we wanted to look at it in this setting. But I think that you can apply these algorithms to any other domain, thinking about some of these other patient-centered outcomes that are not recorded as structured data. We can then take this information further and look at it across treatments to help guide clinical decisions. So here we're looking at the different rates between erectile dysfunction and urinary incontinence over time following prostatectomy. And you can see that, at 3 months, the rates are fairly similar. But when you go out to 12 and 18 months, you have, this is only for prostatectomy. You have higher rates of erectile dysfunction than you have urinary incontinence. When we look at this after radiation, we see flipped results. So really developing evidence that the clinician can talk to the patient about trying to guide those treatment decisions. I think this really opens up the door for patient-centered outcomes research and leveraging it, bringing it into sort of the big data environment, moving away from mailed out patient surveys and being able to look at these outcomes at a population level. So I want to talk a little bit also about where we're generating these data. We're using these algorithms to identify text. I want to talk about some of the important statistical challenges that we have with this data. And I've mentioned some of these briefly. The first challenge we have is missingness and incomplete data. Data are sparse. Unhealthy people are more likely to return to the clinic than the healthy people. So when you think about getting your patient sample in the EMRs, you have to think about this inherent bias and how are you going to deal with this. Data are noisy. We have inconsistent information. We have information mismatch. We have inaccurate information. And so we need to think about how we deal with this. This is very similar to the challenges we dealt with in gene expression data, 20 years ago. And so you also need to think about when we're developing these NLP algorithms, we're giving you an accuracy score. So I'm saying I'm about 89% sure that this patient has urinary incontinence or not. So then when I start developing algorithms, thinking about associations with urinary incontinence, what's predictive of urinary incontinence, I need to start thinking about how do I take those accuracy scores into account when I'm starting to look at regression models and things like that and the standard errors. So I think there's a lot of interesting challenges that we need to think about. And right now, it's an open field. You know, people aren't really thinking about these data and the challenges with the data right now. We also need to think about data capture and measurement. They're not consistent. One of the projects we're looking at is pain measurement during the inpatient period. And so a lot of the packaged algorithms expect that you're taking measurements at specific time points or at regular time points. But when you look at this information in the EHR, there's no consistency. You know, you're taking the measurement when the patient is requesting his PCA, you're taking the measurement when the patient's complaining, or when the nurse is doing rounds. So you need to start thinking about, you know, this inconsistency in how we're capturing the data and the time intervals involved. And also, the data is hierarchical. One of the strongest predictors of receiving a typical an opioid medication after surgery is the division who you went to have the division who you saw in your hospital. So it's practice culture, it's training culture, and so data are nested. So we need to think about that when we start looking at these data. The patient belongs to the clinician who belongs to the division within the hospital. So all challenges that we need to think about, and people are people are thinking about this, but I think there's a lot of opportunities to really dig deeper into these methodological issues. And I just said that. So we've been thinking about this, and what's nice is our biostatisticians are so excited about some of the data that we have, because for them, it's offering opportunities for them to carve out this new field in, you know, thinking about the biostatistics of measuring and using electronic healthcare records. We've developed a couple new methods for dealing with these data. The first is a non-parametric method with robust linear regression and k-medians cluster package to look at disease trajectories. So for that, again, we're taking into account that these measurements, when we're looking at trajectories, these measurements are not taken at regular intervals. There's randomness to that. We have a lot of outliers in this data. We're also looking at methods for estimating the causal effects in the presence of differential missing data across sites. So again, I said, you know, healthy patients, less data. So we're looking at differences in imputation methods. Do you impute this data before you cluster the patients? How are the different time intervals, and how does that affect your standard error and your bias? We're also looking at testing portability of prediction models across sites. So as I said, it's really important for the algorithms that were developed that we can use these algorithms in other sites. So we're thinking about, how do you measure the accuracy? There's a Gini index that can compare models, but there are other novel ways that you can think about comparing the transportability of some of these algorithms across sites. Sorry, this is some of the clusters that we've been developing for our pain score trajectories. So what you see in the first part of the slide is what we've done is we've looked at pain trajectories across the inpatient stay for all patients receiving 4 types of surgery. We then use all of the data points for their pain scores. So some patients had 10 pain scores, other patients had 150 within a 3-day period. So then we cluster the trajectories, and here we're looking at principal component analyses. And then these were the pain trajectories themselves. And what we found is the patients who had these trajectories that, this is not working, that went up before they were discharged had higher rates of postoperative complications and higher rates of 30-day readmissions. So this is something you can think about. You can start taking this into account when you see a patient in the clinic and their pain scores are gradually increasing. It might be a way to think about, you know, this patient might need additional monitoring, this patient might need additional resources, and we're able to do this before they're discharged. So there's still action that can be taken. So I think that what we're developing by using these electronic medical records is we're trying to learn from all the data points available. You know, we've been developing a lot of projects using our pipeline, and it's really enabled a lot of opportunities for research across communities in our institution. So if you think about our patient cohort, it's providing opportunities for all types of studies. We have junior faculty coming to us trying to get preliminary data for ongoing projects. We have junior faculty who are trying to carve out some information, want to know more about their patients. We have the infrastructure set up so that students, so medical students, PhD students, residents, fellows, can come with a very specific type question and do a research project within a period of 3 to 9 months. So it's important because they don't have to spend the first 3 to 9 months of their fellowship trying to gather the data. We already have that set up for them. It also offers a lot of teaching opportunities. I think we're training the next generation, and we need to think about these important statistical opportunities, important software development opportunities, and new ways to think about and extract this data. And some of the research that we've been doing with these cohorts, I've had listed up here. From a health services research point of view, we've been looking at guideline recommendations. So as I mentioned, we're looking at, for example, the US Task Force recommendation to stop all PSA screening in 2012. And so with that information, we can look at, one, how did clinicians react to that guideline change? We saw most of them just still kept doing PSA tests. But then we also want to look at, you know, could these guidelines affect staging of diagnosis, and could they affect treatment outcomes? We're also looking at guidelines from the Center for Disease Control regarding opioid discharge medications or opioid inpatient medications. So we can look at our cohorts to see, are these guidelines being followed? For our surgical patients, they're discharged. A lot of them are not following the guidelines for opioid prescriptions. However, what we can do is we can see where they're not being followed and why they're not being followed. And mostly what happens is that there are a specific population of patients that we can identify that the guidelines aren't appropriate for this type of population. So for example, in particular with the opioids, there's patients who are depressed and taking SSRIs, which is a serotonin inhibitor. And so those patients don't do well on opioids because SSRIs block the cytochrome P450 CYP2D6. So therefore, the opioid is not metabolized. So we can use these data to, one, look at these guidelines, two, identify, are there specific populations that might need different types of medications, different types of treatment, and really it's a step towards that precision medicine and identifying the right treatment for the right patient based on evidence that we have. As I mentioned, we're also doing research in the patient-centered outcomes. I showed you our information for prostate cancer and urinary incontinence. And we're also getting into the personalized care and prediction models. Another thing we're doing with our opioid information is we're looking at, can we identify the right amount of opioids that should be going home with each patient? So right now, the guidelines are, you know, anybody getting knee surgery goes home with 30 pills of Narco, for example. And so maybe that 30 pills isn't right for every patient. You know, that's the average patient. But how do we start identifying which patients are going to need more or less opioids? Some patients don't even use their opioids. So we can start generating this evidence to really guide those treatment decisions. We also have been doing some work taking these cohorts to investigate generalizability of clinical trials. Here I'm showing we did a clinical trial at our institute looking at the effect of perioperative gabapentin on postoperative pain and opioid cessation. So first they did a very expensive randomized controlled trial. It included 422 patients. And their results were that the gabapentin, which is an alternative to opioid, had no significant decrease in pain. However, it reduced the amount of opioids that they were given. So This was a 4-year trial, very expensive. So we said, I wonder what this looks like in our EMR data. So because we've had our cohort developed in a matter of, I think, 3 or 4 weeks, we were able to replicate the study results from the clinical trial using a population of 4,000 patients, I believe we have. Yeah, over 4,000 patients. And we showed the same results. So one, using gabapentin did not change their pain outcome. However, we saw a 37% reduction in the amount of opioids they needed during the inpatient stay. So this is a good example of how we can use this data to look at to start thinking about research in a different way, to start, what is the generalizability of these trials at a much less expensive and much more diverse population. For thinking about the methodological opportunities we have with these cohorts, we have BMI students who are working in my group right now developing predictive models, working on open source software tools. So some people in our group are contributing to the Odyssey common data model that I spoke about earlier. We have students working on unsupervised machine learning algorithms, missing data imputation. We're looking at disease progression models. So how can we start measuring disease progression using the amount of data we have? We have biostatistical students. We have postdoctoral fellows getting much bigger projects. And we also have clinical informatics people who come in. They take a year off their residency to come in and learn about informatics. So a lot of opportunities for teaching and methodological projects. So where are the opportunities? Not everyone is going to go out and build their own EHR system. So I wanted to talk kind of about some of the opportunities I see and where some of this work is going. So has anybody heard of the Cures Act? The Cures Act, which went out, I believe it was 2 years ago. So the Cures Act donated $4.8 billion to advance research. It provides hope, it invests in research, and it streamlines like FDA guideline and regulatory information. Each of the projects here under the Cures Act have some type of computational or informatics component. For example, you have $1.8 billion going to cancer research. You have $1.6 billion going to brain diseases. You have $1 billion going to opioid abuse. And so these are all things you should start thinking about. As an informatician, when we're starting to think about these data, how can we start leveraging, some of the tools and the opportunities that are out there to address these questions using our EMRs and some novel statistical methods? When you think about what's being funded right now from NIH, some of the most funded projects are on opioids, machine learning, obesity, precision medicine, adverse drug events, and patient safety. So all of these topics have some type of component that can be leveraged through bioinformatics, through EMRs, and these are things that are getting funded. So you should, for opportunities, I think there's a lot of opportunities. I can see our EHR cohort addressing every one of these questions in some form or another. The Institute of Medicine has also put out an initiative to look at social determinants of health using electronic medical records. So they have suggested that somehow we need to start capturing this information in the electronic medical record, and they even give you how this information should be captured and the frequency that it should be captured. These are opportunities. These are opportunities to think about how can we capture this information? How can we incorporate this into the EMR? And more importantly, how can we start incorporating this into our analyses when we're thinking about clinical research, when we're thinking about clinical analytics? These are all opportunities. If you think about the hot topics in 2017, so if you look at the news media, the hot topics, the things that have been reported most in 2017, smartphones, wearables, real-world evidence, remote care. But look at the middle one, prediction, precision medicine, pharmacogenomics, participatory medicine, so capturing information from the individual. These are all areas that everyone's talking about. And we're getting funding from these from NIH. So there's really a lot of opportunities to think about how your research can leverage some of these things that are being funded, that can leverage how this information is being extracted to answer these questions. And finally, NLP interfaces, burnout, which I spoke about earlier, and new MD competencies. You know, the clinician now has to think about not only how to treat the patient, but how to document that patient, how to get the information in the EHR, and how to synthesize that information when they go to treat the patient. So I am just going to wrap up here. So I think that, you know, when you think about the big data movement, there's been rapid development in computer and laboratory technologies. Data storage and processing are no longer limitations. We get voluntary data contributions. We have information coming in from wearables, from patients are sending in information. We have this outside data we can leverage, public health data, environmental data, incorporating omics data, right? Integrating into the healthcare record genomics, proteomics, all of this information to start thinking about disease. And we also have global collaborations where we're sharing information, trying to share information not only across sites, but across institutes and across countries. So then the question comes, you know, how do we treat population health while dealing with the precision medicine, right? It's a challenging question. We're trying to look at population health information while treating that individual patient. And so I think there's a lot of opportunities, and I think that data can really, the EMRs can really generate data that can help drive some of these decisions. And so with that, I think there are opportunities, as I said, in tool development, in dissemination. A lot of the tools we develop are open source software. It's really interesting to see when you do develop these tools and you put them into open source software, how other people utilize them, how they refine them, how they package them, how they promote them. Your tools that you develop can be used in all different ways that you didn't think of, but it really gets to this dissemination of the information. And so I think that our group has really worked hard on overcoming the hurdles using electronic medical records. I've really leveraged my past experience using gene expression data, where I think there are a lot of similarities, as I mentioned. I believe we can really accelerate data-driven evidence, looking across multiple collections of big data sets, developing novel models for describing and managing data, and real-time monitoring, which is something we're really challenged to do, is getting that real-time monitoring and then bringing that information to the point of care. I think it's important that we remember our experiences from other areas. You know, electronic medical records are not the only ones dealing with a lot of these issues, and so it's important that we think about that. And we need to think about disseminating and sharing this information in novel ways. Of course, I have a very, very multidisciplinary team. I have worked with a lot of clinicians, methodologists, staff, and students, and it really is a multidisciplinary approach. I alone cannot think of these problems or the solutions to these problems by themselves, and it's been really exciting working with a dynamic group who can think about these questions in different ways. And so with that, I will stop. I will put my disclosures up. This work is funded by NCI, AHRQ, and AstraZeneca. And I would be happy to take any questions you might have.
Questions from the audience?
In the beginning of the talk, you had mentioned there's a big issue with the physician-EHR interface. And, you know, as this becomes a bigger part of healthcare, I was curious to hear your thoughts on how you think that'll change. And second, more technically, is I'm just curious what kinds of programming environments your group uses.
So first question is dealing with physician burnout, right? So that is a big challenge, and a lot of people are approaching it in different ways. Some groups are developing smart forms to capture the information. There's a lot of things going on with doc talks, so the narrative text can automatically be translated and transcribed into the EHRs. but there aren't any good solutions right now. So if you look at some of the rates, there's been some publications looking at the rate of physician burnout, and it's just escalating. And it's interesting because this great increase corresponds as soon as the institute installs the electronic medical records. So physician burnout is a big challenge right now. And again, it's hard because these records are only useful if you get good quality data put in. But somehow, you know, we need to make that easier and facilitate that from the physician side. And sorry, your second question was, what kind of programs are we using? So most of our programs are developed in Python. And then for the NLP, we're using context. We've used NegEx sometimes. We have developed the GATE software system, which is used for NLP. But we're moving more towards just a Python code that incorporates context and NegEx.
Now let me ask you a follow-up question on the ontology to clean up the language, to make the word more disciplined. There is a database in Stanford, but what about a nationwide effort to standardize?
Right. So for ontology, so what we do when we're developing our phenotypes, we identify these clinical terms, and then we map our clinical terms to like SNOMED and other ontologies to grab all the synonyms. And right, is that answering? Yeah. And so then what we do is in our algorithms, we don't code every synonym for the different ontologies. We just link to the different thesauruses and bioportal to incorporate all the ontologies. And then we share these terms and the mappings to the ontologies through the pkb.org repository.
I just wonder, when this is open source and transparent, that's all good. But to what degree we wish for a national authority to have a staged lock-in of the dictionary?
Right, and that's challenging. I mean, because there are no standards for how to do this. And so I think that there needs to be, there needs to be some national efforts on how we do this. Now, I talked a little bit about the OMOP and these common data models and Odyssey, and so that's not a national effort, right? It's a consortium, but it is gaining interest, and now having the VA map to that system, that will be a very interesting thing to see how that takes off.
Last question is continuation of the question about burnout. The data entry is dirty work and it's difficult to incentivize. How do you see would be some mechanism to reward that effort?
Right. So some of the we've been looking at that question a lot for burnout. And so some of the burnout comes from like documentation of quality metrics and quality reporting. Clinicians have to write, okay, I documented this, I documented that. So some of the algorithms that we're developing extract this information automatically just based on the free text. So for example, one of the quality metrics that urologists have to record for prostate cancer is a digital rectal exam. And so there's check boxes the clinician has to do. So what we're able to do is we're able to find that they've documented this in the electronic healthcare record. So we're pulling this out and generating automatic reports and sending them to the hospital so that the clinician, it just reduces some of the burden of the clinician. So there are innovative ways to think about how to grab that information out and reduce the burden on the physicians. So.
Any other questions? Okay, let's thank our, hold on, Jeremy.
So I'm picking, the field of epidemiology for many years has been thinking about, observational data with many of the same sort of messy issues, and they worry a lot about bias and confounding. And so what's fundamentally more promising about EHR that epidemiology hasn't been able to achieve?
I don't think anything other than the volume of data we have and the missingness of data. So in the healthcare record, they're just being randomly recorded. And so how is it different from epidemiology? It's the same questions, just like it was the same questions in gene expression. But I think that because of the volume and the size of the data, we need to think about new ways to think about some of these questions. And for example, when we think about accuracy scores and things like that, in epidemiology, sometimes we have very hard outcomes. they're easy ones to look at, like death or mortality. There's no inaccuracy when I'm saying this person died or not. But when we start looking at some of these machine learning outcomes, some of the outcomes we generate from NLP, we have to start thinking about accuracy scores, how to put that into the algorithm. But you're right, they are the same questions that we keep revisiting over and over. So maybe it's not the new algorithms, it's the new systems or software to deal with the data formats and the data types we have.
Great talk, Tina. When you do some of your analyses, do you ever look at the, instead of at the patient level, at the provider level? Like,
yeah.
If certain providers are copying and pasting from note to note
right.
to note, and you've got one doctor who spends 15 minutes documenting everything in the world versus another
right.
doctor who spends 2 seconds.
Yeah.
Like, do you account for that in your analysis?
You can, and there's a lot of techniques. So you can look at like keystrokes they've used to input the text, so you can tell if it was copy pasted. We haven't done that. There's been some reports that have done that. What we found works even better is we go back to the clinician and we show them, okay, here's the data. Here we were able to pull this out of the documentation. And we found that as soon as they realize that we're using their documentation, they become much more conscious of what they're putting in there. We've had so many clinicians say, oh, I didn't know anybody looked at that other than me. I'm like, yeah, we do. And EPR, I don't know what that means. No one else does either. So really sharing that information has been really useful to make clinicians aware that we can use this. And I think that the more proficient we become in utilizing this information and generating research using this information, the more that they will be aware that this is important and useful. So.
All right. Microphone over there.
Question? Yes, thank you.
Okay.
Thank you. I have a question which is, this is not my field.
Yeah.
And as I look at some of the data in the area of Alzheimer's, they have a program right now using amyloid PET scan to determine whether that could be a biomarker.
Okay.
Yet we know from the big data, or a lot of people have shown, that that the beta amyloid, the plaques, are really antioxidants. So I'm confused because antioxidants to me is a curing agent. That's it.
Right.
But yet they are looking at the same thing, whether they are the cause of the Alzheimer's.
Sorry, what was?
So the question is, that big data telling us, are these contradictory to each other?
Telling us, sorry.
I think you're asking about some contradicting evidence about plaques being causal, but on the other hand, being reported as.
So, as with any observational data, we're just looking at what the data is. It's really hard to have a causal inference using this data. I think it can really guide us. You can look at it and say, I have a patient who has, diagnosis XYZ and has lab results ABC. How were they treated before? What are previous treatments that have been done for this patient that were successful? But it's very hard to look at causal relationships, I think, with this data. It can generate evidence. It can help guide us think about what are the right treatment options. But I think that it needs to be used cautiously and just, viewed as evidence-based information.
So that's why I was very surprised that some of the data, there are bad data going in, and of course that data will come out. But yet they are spending a lot of money today, have this kind of program to determine whether amyloid is the biomarker.
Right, for biomarkers. And so one of the things we're doing with the EMRs is is we're just looking at what biomarkers are recorded. We're looking at where they're recorded. We're looking at if they're recorded. Some of the, if you think about for cancer registries, they're trying to capture all the biomarkers associated with particular cancers. So what we can do with the EMRs is we can identify, are these being recorded? You know, what is the information there, and extract that information. And, you know, as I said, it just depends on the information that's put in there. It could be contradictory, it could be wrong, it's incorrect. But hopefully, because you have the mass information, those turn into noise and you can get a strong signal with some of the real important data.
I think it would be very useful.
I think the discussion can continue afterwards.
Okay, thank you.
Yeah, thank you.
Thank you.
All right, let's thank the speakers again.
Hey, how you doing? Nice to see you.